Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
All right, welcome to our Addiction 101 for medical students, which is what we decided to call it. Dr. Cara Poland is joining me again today. And this series has been long in the making. And I believe the last time we talked to record something, kind of an intro to the whole series, was a few months back. But today, we are going to talk about pregnancy and addiction stuff. And before we do that, though, Dr. Poland, who is Dr. Poland?
I am a board certified and fellowship trained addiction medicine specialist practicing out of Michigan State University in Grand Rapids, Michigan. And I work predominantly clinically with pregnant people with a substance use disorder. So I'm excited to be here. And my other hat that I wear is I am a medical educator. So I work with everyone from medical students to practicing physicians and non-physician healthcare workers as well.
Yeah, you have quite a few hats, actually. They can look at your LinkedIn, which we'll put a link in the show notes for that. But all right, so today's topics are going to be like opiates, nicotine, throw in maybe some alcohol use and marijuana use in pregnancy, drawing on Dr. Poland's experience. And I think we'll use questions like we usually do as a springboard for these topics. So first up, thanks to Amboss for providing these, we've got the first 24 hours after delivery, a 2888 gram, which is 6.4 pounds. Male is not feeding well. He has a high-pitched cry and is diaphoretic. He was born 38 weeks gestational age to a 30-year-old multip after an uncomplicated labor and delivery. APGARs were 8 and 9 at 1 and 5 minutes. The mother had a lack of prenatal care. And medication-wise, she takes codeine frequently for dry cough. The infant's temperature is 37.8, which is 100 Fahrenheit. Pulse is 165, and blood pressure is 83/50. On physical examination, the baby's hyperreflexic, has tremors, and an excessive startle response. The baby's swaddled to prevent excoriations, and fluid resuscitation is initiated. A CBC and serum levels of glucose, bilirubin, and calcium are normal. And the question is, what is the most appropriate next step to treat this newborn? And we've got A, oral morphine therapy, B, oral clonidine, C, intravenous calcium gluconate, or D, therapeutic hypothermia, or D, intravenous ampicillin and gentamicin combination therapy. All right, so Dr. Poland, is this something that people deal with in the labor and delivery suite in the nursery when a mom is suffering from addiction?
Absolutely. This is kind of that high-pitched cry and diaphoretic. I think on a board exam question should automatically put on your differential opioid withdrawal. That codeine syrup is kind of giving you that slam dunk that's the diagnosis that they're looking for. I wish always on a question like this, there was an E, talk to the mother. Somebody who didn't receive prenatal care was probably really scared to come in for prenatal care, possibly because of her substance use. And if that's the case, then we want to make sure that this mom knows that she's going to be taken care of and that her baby is going to be taken care of. So it's one thing to know what medications to start, and it's another thing to know that we need to have kind, compassionate, caring conversations with this mother that are private, and then with anybody that she wishes us to help her navigate those conversations within her life, whether that's a father of the baby, a parent, another support person for her. Now, when we look medically at this baby, we're going to want to give the baby oral morphine therapy. These are kind of classic symptoms of neonatal abstinence syndrome, again, likely caused by that codeine use. And, they've already done what I like to call the warm cuddles they've provided the baby with swaddling. We'd also want to encourage lots of skin to skin or cuddling from mom. Baby knows mom's smell, baby knows mom's heart tones. Those can also help really calm baby. If she had been on medication for addiction treatment and not using codeine, outside of that, we would be encouraging breastfeeding as well.
Gotcha. So neonatal abstinence is the diagnosis and oral morphine is the treatment. Let's talk a little bit more about neonatal abstinence and its cause, opiate use disorder in the mom. Is there a difference in neonatal abstinence clinical presentation and course if depending on what opioid the mom is addicted to?
Yeah, certainly. If mom was taking a short-acting opioid, then the course is going to be, it's going to kind of show up in the baby faster than if mom's taking a longer-acting opioid. Most hospitals in general have a kind of 5-day window of observation for opioid withdrawal so that they can kind of catch the folks that are on longer acting opioids like buprenorphine or methadone, but also, catch the babies that need additional treatment from shorter acting opioids as well. So in general, they tend to give about a 5-day time course for this kind of coming up. I'm a little concerned about that time course of the first 24 hours after delivery. Certainly with a short-acting opioid, that is reasonable, but also within a 24-hour time period, baby could also be withdrawing from other substances. The one that notably comes to mind that's often comorbid in my patient population is tobacco use, because that nicotine withdrawal can happen in that 24-hour period. Also, of course, with vaping and other methods of obtaining nicotine in mom's system.
Okay, so you can expect to see an overlap of symptoms with nicotine withdrawal or opiate withdrawal in the baby, or actually too, probably even with like some certain SSRIs as well. I think we see kind of a constellation of symptoms that can look similar. Is there a way to differentiate them? Hopefully the boards wouldn't do this to like a medical student real hardcore, like make them differentiate, but they could.
They could, and they would be very mean if they did. I agree with you. But I think it's really unlikely that they ask people to differentiate between like nicotine and codeine in this case. Babies don't have a lot of ways to show they're in distress, so that high-pitched cry is often the words that the boards like to use when they're talking about opioid withdrawal.
Yeah. And I guess now to move into a couple leading questions. So what can is there something we can do to decrease the intensity or incidence of neonatal abstinence in women who have an opiate use disorder?
Yeah, we can get them into treatment, right? This in this case, this mother didn't have treatment, right?
Right.
So we would want to make sure that we get people into treatment. People in treatment for a substance use disorder during pregnancy have better outcomes. Their babies have shorter lengths of stay in the hospital than babies who are born to moms on unknown substances or unknown quantities and frequencies, such as it appears in this case. Certainly getting people into treatment also allows us as doctors to have those conversations with our patients. So when she comes into the hospital, she knows what to expect. We know that young children, including newborns, get their emotional tenor from mom. So if mom knows that baby's at risk for neonatal abstinence syndrome and what treatment of neonatal abstinence syndrome looks like and what that monitoring looks like during her pregnancy, maybe has an opportunity to meet with a neonatologist or a pediatrician to kind of ask any questions she has of them, then she comes in with that knowledge, and knowledge is power, right? And so now she knows what to expect when she delivers this baby. She's calmer, baby's less likely to get agitated. If baby does get physiologically agitated, mom knows some of these tools to help soothe baby, and so they're more likely to not need pharmacologic treatment with that oral morphine if they've had, if mom's been prepared, and any other caregivers, moms, dads, whoever mom's support person might be.
And that probably is really why we treat in general. Because I think, you learn in med school that pretty much opioid withdrawal is not life-threatening. So, but like the thought of being like, deal with it, baby, is not exactly a palatable thing, I think, just as a knee-jerk response. But the point of treating mom and trying to decrease the infant's experience of neonatal abstinence syndrome is to ensure that emotional development and safety of the baby's kind of, early neurologic connection building that is so necessary and opportune in that first, really the whole infancy period, but probably especially in the first couple weeks. And so I guess what you're in summary saying is like this trying to prevent neonatal abstinence by treating the mom, and then treating neonatal abstinence when it shows up in the baby is really trying to enhance the maternal infant bond and all the good we know that comes from that in terms of critical development for a child. Is that a good summary, I guess?
I think that's a great summary. The other thing is we don't want to discount the power of dads and other primary.
That is true. I will second that.
So what they've done studies of newborns, right? At about 2 weeks old, they have, neck control, right? And so they put babies, they've laid babies down and they've had like dad and random dude on opposite side of baby and had dad and random dude talk. And baby will actually, at 2 weeks old, turn their head toward their dad.
Interesting.
So even though we know there's this connection with mom, we know that babies kind of calm down faster for mom, there truly is baby does have that connection to dad. And the more people that we have, not only supporting that mother infant, but also that family unit, I think the better off we are as a community.
Yeah. Appreciate you mentioning that as a dad to 4 kids. All right. So a few other issues with opiates and pregnancy. One of the things you hear with respect to medication-assisted treatment in pregnancy is that...
Whoa. It's not medication-assisted treatment. It's medication for addiction treatment.
Medication for addiction treatment. There we go. And actually, since you're making that point, why is that distinction important?
Because medication doesn't assist the treatment. Medication is treatment.
There you go.
Medication is integral to treatment. And when we call it medication-assisted treatment, we minimize the importance of medication. And our studies really show that medication is a necessary component, at least to be offered to all patients. Obviously, I'm not going to be at somebody's house forcing them to take their medication every day. But making sure that all people with a substance use disorder have access to medication is really important.
Appreciate that. Thank you. And we did in this series, there's a section on the language of addiction. So that's worth looking up. And we kind of talk about that a little bit more in detail. But to return to that question, is it safe to withdraw from an opiate during pregnancy?
In general, yes. We know that.
Oh, for the fetus, sorry.
For the fetus. In general, yes. We know that baby's nervous system isn't really developed to be able to feel withdrawal until the 3rd trimester. So there is some concern that there might be some fetal distress during the 3rd trimester in which we might want to put mom onto a monitor if we're going to be withdrawing her during that later parts of pregnancy.
And is, pursuing an abstinence strategy or a weaning off medication for their opiate use disorder treatments, as some women want to do. I guess, can you just comment on that?
Dr. Beeman, you said the key words, as some women want to do.
Right.
If a patient's sitting in front of you saying, I want to wean off of this medication, then our job as the physician is to say, these are the risks and benefits of choosing to do that. If it's not successful, because we know many people who try to wean off of these medications are not successful, I want you to know that I'm still here to provide you care, regardless of whether or not you need medication appropriately to treat your substance use disorder or not.
What do you tell a woman who comes in and is like, I found out I'm pregnant. I have been stable on, let's say, methadone for 3 years. Last time I used heroin was, 2.5 years ago or something. I want to get off methadone. What would you tell her?
First, I want to ask her a little bit about why, but once we kind of have that conversation, then I ask if I can share what some of the information is that I know, because my role as your physician is to share my medical knowledge with you so we can make the best decisions in your life. And no matter what route we go, staying on the medication or stopping the medication, I want you to know that I want to continue to be your physician throughout your pregnancy and into the postpartum period, regardless of if you're on medication or not. And just ask permission to share some of the data with them. And I say things like, I want to share the data because statistics have meaning, but you're not a statistic. We need to figure out what it actually would look like in your life.
And if she's like, well, I just don't know what to do. I don't want to be on any medication during pregnancy. How would you respond to that? Laying out those risk and benefit considerations.
I tell them that the benefit is certainly there. And if you were my family member, I would be telling you that I highly recommend you stay on the medication.
And what can I expect then when my baby's born? Let's say I continue on my methadone. What happens when my baby's born? Is baby going to be sick and withdraw?
So there is a risk that baby might have something called neonatal abstinence syndrome, which is when babies withdraw from substances. However, nobody at my hospital is really excited about baby torture. And we know that withdrawal doesn't feel good because it doesn't. And so if baby does need withdrawal treatment, we provide them with withdrawal treatment. And what that looks like is in the early stages of withdrawal, if baby has withdrawal, and not all babies have withdrawal, I call warm cuddle stages. And then I go through kind of what that means. What are some of these environmental things we do? And then I talk about if baby then still needs medication, if medication is appropriate for that child, then we will give your baby medication. And we use literally droplets of morphine, tincture of morphine, in order to treat that baby. So we give them as little as we can to keep them comfortable. And if baby does need medication, then they'll be monitored to make sure that they're comfortable, feeling well, but also not given too much medication. And when we look at these babies out to 36 months of age, their brain development is not different than a baby who was born to a mom not on medication for a substance use disorder.
That's good. Yeah, that's good. That was the response I got recently was, oh, really? When saying like not all babies withdraw, because the experience of a lot of people who suffer from an opiate use disorder is, withdraw, the how terrible that is what drives their continued use to a large degree. And yeah, no parent wants that for their kid.
And that's a sign that this parent is trying to be a good parent, right?
Yeah, which
they don't want their child to suffer.
Exactly. And that's, I would say that's the majority of women who suffer from addictions in pregnancy. I just, that's the case. There's a conflict internally often, and part of it is driven by that maternal instinct, and we need to be treating that and enabling women to get better rather than just be so afraid they're going to be punished for having this problem throughout their pregnancy and certainly when the baby's born. So, all right, let's say a patient comes in with a history of heroin use and they're like, I want treatment. And you do a pregnancy test in the office before you see them and it's positive, and you go into the room and what's your conversation if, say, she's 8 weeks along, just found out she's pregnant today, and is coming to you for her substance use treatment?
Oh yeah, that's a tough one, right? I mean, people are kind of in shock if they weren't trying and weren't expecting to become pregnant. I've been there. So it is a hard, that alone is a hard conversation, is a conversation to be had.
All right, fine. Let's switch it up then. Let's take that out, because that is true actually. Now I'm thinking of the times I've been like, oh, so
you're pregnant.
I have some news for you. And you try to like gauge on.
But I mean, that is what happens, right? But
100%.
That's one piece of the conversation. But, even if she did or didn't know she was pregnant before she walked in for treatment, it doesn't matter. She should be offered treatment. And it's just at that point about figuring out what is the right, dose of treatment. Is she interested in an abstinence-based program? Is she interested in buprenorphine? Is she interested in methadone? What's realistic in her life? And that conversation isn't distinctly different during pregnancy than it is during for a non-pregnant person, with the exception of we don't really use naltrexone very much in pregnancy. And certainly if she's just discovering she's pregnant and not on medication, most doctors would not offer her naltrexone.
So that's straight up naltrexone, but you've got naloxone and buprenorphine as a combination product, most commonly known as the trade name Suboxone. Suboxone and methadone are two treatment options for an opiate use disorder. And in pregnancy, is there a contraindication to using buprenorphine and naloxone in combination? Is that a concern that should be there?
It is certainly a concern sometimes in people's heads. So it was a hypothetical risk that the naloxone might get to baby and precipitate withdrawal in baby. But when they've actually done a study where in a small number of patients, but they actually did cord blood sampling to look for naloxone presence in the cord blood. And frankly, it wasn't there, or was in such small amounts that it wouldn't be physiologically active in the baby. When the reason it's in there, right, is because if somebody misuses this medication by melting it and injecting it, it can either attenuate the response to the buprenorphine or precipitate some withdrawal if there's already another full agonist in the brain. But when taken sublingually, naloxone undergoes first pass metabolism, so it doesn't really get into the body in significant amounts and is not effective.
So when people have precipitated withdrawal, I think it's important to distinguish then the reason why, if they take, say, buprenorphine, naloxone in combination, when they have heroin on board or another opioid, it's because the buprenorphine displaces the other opioid that's a full agonist, and it's not the naloxone that knocks off the full opioid agonist from the receptors, correct?
Not when taken sublingually, but if injected, then both the buprenorphine has an effect and the naloxone can have an effect in terms of precipitating withdrawal.
And I'm trying to draw out because some people might know there's a buprenorphine mono product, and a lot of doctors will only give that in pregnancy. But do you guys give Suboxone to a pregnant patient?
We give the combination product to pregnant patients in my clinic. And I think most people that have more experience with pregnant women are now prescribing that combination product in general.
And the other option's methadone, and we've talked about that in other opiate lectures or discussions in this series. So there's probably not much really difference as far as methadone and pregnancy goes, except as you get into the mid-trimester period, they can chew up their methadone dose a lot more quickly. So pregnant women often need to have their dose raised pretty often. And actually, because the pharmacological properties often need to split, well, not often, but sometimes need to split their dose twice a day rather than once a day, which is how most methadone is administered in an addiction treatment context.
Same thing with buprenorphine. Sometimes we need to increase the frequency of the buprenorphine during pregnancy.
Oh, right.
But interestingly, it's not often the dose doesn't need to be increased, just the dividing it up more frequently.
Yeah.
So the total daily dose stays the same. Am I making sense?
You are making sense. Yeah. Okay. I can't easily explain that. I mean, I know how it works in theory, but I will I will stumble over trying to explain that in a way that will be helpful. But yeah, basically split the dose 12 hours apart rather than 24, sometimes in pregnancy. Do you do that routinely or?
If the person comes in and is having some form of symptoms around it, most of my patients are already on BID dosing, so they're usually taking their medication twice a day already. And we start to get worried about taking it more than that because it just becomes harder to be compliant with the medication. And also, if you're taking it more than twice a day, it's starting to look more like what they might have done with their heroin use or other opioid use. In their substance use disorder, and that can kind of do weird things to the unconscious areas of the brain and make it harder. So we tend to try to stay at twice a day dosing. Sometimes we go to 3 times a day dosing if the person is really looking like they're going into some form of objective withdrawal signs in between their doses.
Okay, gotcha. And I know your time is short here today, but can you offer before leaving any perspective on peak and trough levels of methadone in addiction treatment during pregnancy?
Sometimes what we do is we split that dose in order to prevent them from their trough from going so low that it's subtherapeutic. And we don't want that to happen because we don't want mom to go into withdrawal and to feel cruddy because they know how to fix that. And you fix that by using another opioid, which is counterproductive to being in addiction treatment. So sometimes we need to keep them from going down, dipping down into that subtherapeutic level. And so that requires us to split the dose and maybe dose increase during pregnancy.
Gotcha. Do you have to do that often or can you just follow clinical symptoms of withdrawal?
You just follow their clinical symptoms and see what they're doing. And sometimes it's good to do an assessment just before they have their methadone dose in the methadone clinic. So you can kind of see a little bit objectively what they're doing. With opioids, your body never becomes tolerant to the pupillary effects. So I'm constantly asking my learners to look at the pupils because you can actually tell if somebody's in withdrawal best by looking at their pupils if you're looking for an objective sign that's easy for us to kind of see.
Gotcha. Much appreciated. Awesome. I think we hit all the topics pretty good there for opiates in pregnancy. All right. So these questions are from Stat Pearls. And first up, first to say, we want to kind of discuss alcohol and marijuana and maybe touch on some pathomimetics of some sort, like cocaine or meth, see how much we can do in 20, 30 minutes. First up, female baby born to a mother, 36 weeks gestational age via spontaneous vaginal delivery. The mother had received regular prenatal care, but reports that during most of her pregnancy, she drank beer in an attempt to medicate her depression. What is the most likely mechanism of central nervous system damage that occurred in the baby? So we have A, enhancement of GABA B receptors, B, increased chloride influx into interneurons, C, decreased stimulation of interneurons, D, increased glutamate exocytosis. There's a lot of $10 words in there.
I know, that's like a mean question, I feel like.
Right, yeah.
So, and then why are you doing this to me?
First, so if there are first years listening, then, just have them, Google all the terms here. But all right, so most likely to rephrase this, it's basically we're looking at a baby who has most likely fetal alcohol spectrum disorder. And the question is, what is the mechanism of CNS damage that would occur in a baby like that? So it's the mechanism of the pathophysiology of alcohol or ethanol on the central nervous system in the developing fetus. So,
oof, it's giving me a doozy. I'm a clinician, man. I'm a clinician. Okay, so I'll do my best. Help me out when I need it.
All right.
So GABA is inhibitory in mature interneurons, but it's one of those ones that flips over. And in developing interneurons, such as during prenatal development, GABA is actually excitatory. So in immature neurons, GABA is excitatory, and it's because of a high concentration of intracellular chloride. So that high intracellular chloride concentration is maintained by a sodium-potassium chloride cotransporter 1, which brings the chloride ions into the immature interneuron. And as the neurons mature, the activity of that sodium potassium chloride cotransporter decreases. So the amount of active chloride extruding potassium chloride cotransporter 2 increases, and that flips it to send the chloride out of the neuron. So eventually then GABA switches from excitatory to inhibitory when the concentration of intracellular chloride is low enough. So alcohol or ethanol, which is what's been exogenously introduced into this baby, is a GABA A receptor agonist. And when it's activated, the GABA A causes an influx of chloride ions into the neuron. And as a teratogen, the ethanol binds to GABA A in that immature neuron, causing the intracellular chloride ion level to increase. So it increases the influx interneurons of that chloride. And because GABA is excitatory in those immature neurons, excitotoxicity and subsequent death of the immature neuron occurs, which leads to that kind of syndrome that we see as fetal alcohol syndrome.
So that's fun, all of that. I love the concept of excitatory neurotoxicity that we see with, I guess, GABA and like glutamate. Or I don't know that they would, like you said, this is a mean question. This level of question may be even for like experts, not necessarily your step 1, step 2, the USMLE, but it gives us a jumping off point for fetal alcohol syndrome. So what I would say is the important things to know about FAS from a testing perspective are to remember kind of the morphologic, the phenotype that has certain hallmarks. So the big one would be, I would say, the shortened palpebral fissures, the smooth philtrum, and especially, I would say, the thin vermilion border at the lip and subnasal skin. I don't know what I'd call that, but the transition from lip skin to regular skin for those who don't know what the vermilion border is yet. So those are the kind of characteristic morphological findings you see with fetal alcohol syndrome. And then related to FAS and its differential, fetal alcohol syndrome is the most common cause of intellectual disability, which means don't confuse this with the tangentially essential knowledge of Fragile X syndrome being the most common inherited cause of intellectual disability, and trisomy 21 being the most common cause of chromosomal intellectual disability. So there's a couple things just to hold on to for testing purposes. But for real life purposes, we turn back to Dr. Cara Poland. What can be said about alcohol use, or is worth knowing about alcohol use in pregnancy and caring for patients who are dealing with that?
I think it's really interesting in this case that they say that she received prenatal care but continued to drink beer. I think one thing that we want to do as doctors is we want to make sure we are appropriately screening our patients and creating an environment that is non-judgmental, where they feel like they can share with us things like, I'm drinking beer during my pregnancy, because I think most people know that that's not a great idea and that has risks for their baby. But there's also so much judgment and stigma around substance use in pregnancy. Well, there's stigma with substance use, and then there's stigma with substance use in pregnancy that goes kind of above and beyond that. And really, as a doctor, what you want to be able to do is create an environment where your patients feel that they can share with you if they're struggling with substance use. during their pregnancy. And I think recognizing that takes a lot of strength from people to be able to come in and say, hey, I'm using substances during pregnancy is really important. I know when I see a pregnant person for the first time, one of the things I say to them is just thank you for being brave and trusting enough to come in to see me, because that was probably really hard to do.
Yeah, totally. You know what's crazy about alcohol use and pregnancy? I don't know, probably at this point delivered at least 1,000 babies. I don't know. But really, I can only think of 2. And, this isn't even that's just the delivery. That doesn't take into account all the prenatal care. But I can really only think of 2 people who have admitted or brought up or otherwise indicated on their own initiatives that they were using alcohol in pregnancy in a risky sense. It has to be more than that, because at-risk alcohol use is certainly much more prevalent than 1 in 500 plus people. Certainly, a lot of women will come in and, I don't want to say be freaked out, but that is a colloquial way of saying it. They'll be freaked out because they found out they were pregnant, but like for the past 3 weeks, they've each weekend gone and had, out with their friends. They had a bachelorette party, the kind of classic, story. And they're like, oh my gosh, am I going to like ruin my baby? And for the most part, in general with fetal development, if it's before like 8-ish weeks gestational age, it's kind of hard to do major malformations of the baby's like organ systems through the use of substances. It's kind of like, before 2 weeks, before like 2 weeks, it's like not impossible, but it's difficult to cause a baby to be malformed through the introduction of teratogenic substances. More likely, if there is a substance that is going to harm the pregnancy, it's going to result in a miscarriage or a subclinical, pregnancy loss. But at any rate, I usually just tell women like, nah, don't worry about it. You're good. That's fine. Just don't do it anymore. And they're like, okay, cool. Because I would say most women are pretty motivated to decrease substance use during pregnancy. But I don't know, just what are your thoughts and experience with alcohol and pregnancy, alcohol use disorder in pregnancy? I don't know if I recognize it enough or if I don't, doing a bad job. I'm not sure,
Most people are pretty motivated in pregnancy, period, right? Like I tell people all the time, I have yet to find a pregnant person who doesn't want to try to change something in their life to improve the outcome of that child. Right. So we even see that with the non-pregnant partner of that person, right? Like that they'll make lifestyle changes to support, improved outcomes. So I think that's kind of a universal. And if we can normalize, if we can use that as a normalization, piece to make it, okay, so your thing is alcohol use. That I drank a lot of Diet Coke and I didn't drink Diet Coke when I was pregnant. And like, that was one of many things that I changed when I was pregnant to, and I definitely drink Diet Coke today. Now that I'm not pregnant, right? And so we see that's kind of a normal part of pregnancy. So sometimes normalizing some of that is helpful. I think universally we could do better with screening during pregnancy. The United States Preventative Services Task Force has said that screening in pregnancy is likely helpful. Screening in people who are over 18 is helpful, and screening in adolescents between 12 and 18, it's a little bit unknown. One of the drawbacks is there's all these screening tools, so they're all different, and none have been studied. They've all been in 2 or 3 different studies, and so it's hard to know which is the best screening tool. There are some that are specific to pregnancy. And I think if we can start by just normalizing it by universally screening people using validated tools, that's the best place to start.
How about this? I'm proud to say I've been told I have honorary ovaries because of being an OBGYN. And therefore, what if I came to you, how would you do a screening if I were the pregnant lady? I'm like, hey, Dr. Poland, nice to meet you. What's up?
I would not say, you don't use substances, do you?
Okay, so that's good.
Because that clearly has a right answer, right?
Right.
And sometimes when people haven't been trained, that's what they do.
Yeah.
With alcohol in specific, I personally like the single item alcohol screening tool, which is, do you sometimes use beer, wine, or other alcoholic beverages?
Oh, yeah, of course I do.
Okay, so then I would want to follow that up, right? So we're going to say, when was the last time you had a drink?
Honestly, last night.
Okay, what was it?
A White Claw.
Okay. Are we pregnant right now?
I don't know. Look at my test over there. I know I had to give a urine sample when I came in for this appointment.
That was supposed to be a background question.
Yeah, I know. Oh my gosh, yes. I just found out I was pregnant. I don't know. I must be 12 weeks along.
Okay. Well, we know that there are some risks to drinking during pregnancy. How confident are you on a scale of 1 to 10 that you might be able to cut back or stop drinking on a regular basis?
I know I shouldn't, but every time I try to quit, I get the shakes,
Yeah.
But I don't know, about a day after, maybe a little bit less than when I drink. I gotta take something so I'm not like real anxious, worked up, and shaky, and I just feel crappy.
Yeah, that's really hard. I'm really sorry. That sounds like it's kind of miserable, isn't it?
Yeah.
Are you interested in?
I'm a terrible actor.
It's okay. We have some treatment for people who want to cut back on their alcohol use. Is that something you might be interested in?
Yes, that is something. What do you mean? I didn't know that.
Sure. Why don't we talk about that? Well, now that you're pregnant, you kind of get a free pass to the front of the line. So we can work with you to make sure that we keep you and your baby safe and provide you with medications to help support you in your brain and kind of that detox period when you stop drinking, so that we keep you safe and we keep your baby safe. And then we can talk about what sorts of medications are available longer term to support you during your pregnancy and beyond, in terms of decreasing and maybe even eliminating that alcohol use. We know there's not only risks during pregnancy, but risks for general health, whether or not you're pregnant. So maybe that's something that we can work on together during your pregnancy and beyond.
Yeah, sign me up.
Woohoo!
So does it usually go like that? No, not really.
No, not. But here's the thing: people are really motivated during pregnancy. So if there's a time to hook them, often pregnancy.
It's then, yeah.
It's time to try, right?
Totally.
And asking, I did a lot of somewhat closed-ended questions. That was bad. But doing, a little bit more, letting them tell you what's going on. What do they drink? How often do they drink? What is it? Trying to get some of that information is great, but also just understanding how it fits into their life and how they're feeling, and what might be reasons that they want to discontinue use, right? Like it's that whole motivational interviewing thing.
Yep.
And just trying to figure out where that person is. What you don't want to do is you don't want to scare her away from prenatal care.
Absolutely. Yes, I will second that. Two things. One, can you talk about SBIRT? And two, what are the medication options for alcohol use disorder in pregnancy? Because I know we don't really want to give, naltrexone injections in the context of opiate use disorders, but that's pretty much, I think, only because they haven't been extensively studied.
Well, and naltrexone is an opioid blocker, and at the end of pregnancy is labor and delivery.
Right. And
that's
90,
yeah. So we got to be careful, right? Yep. We got to just be careful. So if you're going to start naltrexone during pregnancy, then you have to have an exit plan for toward the end of pregnancy. And for that reason, we often reach for acamprosate during pregnancy, which is the kind of other FDA-approved medication. In non-pregnant people, we often reach for naltrexone first. And that's mostly because it's either a once-a-day medication or a month-long injection. So it's just easier from a compliance standpoint. Whereas acamprosate is 3 times a day medication, and that's just a pain in the neck. But if you're going to forget, the fewer times you have to remember to take the medication, the more likely anyone is to remember it, right? And when you add in, I swear, when you add in that middle of the day dose, like
that one's tough.
All bets are off because you just get busy, right? Like you just get busy with life.
Absolutely.
So acamprosate often is kind of pulled off the shelf second. Naltrexone is metabolized by the liver. So if you have like a case on boards and they're giving you AST, ALT, and they're asking you about alcohol use, you're going to want to know what those levels are because they're meaningful in terms of that. And then acamprosate is excreted by the kidneys. So you'll want to make sure if that information's on the question, they might be trying to get you to differentiate between acamprosate and naltrexone. But in pregnancy, we tend to pull acamprosate off the shelf faster. It's also important to know that with either one of those medications, you can the patient does not have to not drink at all. They can continue to be drinking.
As opposed to something else? So that was a leading question.
As opposed to disulfiram, which we hardly use clinically, but it shows up on every single board exam. So know yourself something.
Right. I've never seen a patient on disulfiram. Ever.
I've seen a handful.
Like not once.
The studies show that it's not really effective unless the person is daily observed therapy, because with disulfiram is the one that blocks the metabolism of alcohol, and it causes them to build up acetaldehyde. And so then that's what causes the flushing, the nausea, the alcohol intoxication that people can have. It's the same thing that causes people to when somebody's drinking to like vomit and feel sick if they've had too much alcohol, same thing. So that acetaldehyde buildup happens really fast for somebody who's on disulfiram, but it's super short acting. So if somebody wants to drink, they just have to stop even as little as 24, but most people will not take 2 doses and then drink the next day.
Interesting. Okay. So you got...
So if you don't have somebody kind of monitoring your intake of the medication, sometimes if you don't take it, you don't have the negative effect.
Right. That makes sense. So basically 3 medications to treat an alcohol use disorder, officially at least. Disulfiram, which is more of like a theoretical boards type drug that's worth knowing about, mainly for board exam purposes, and the reference to disulfiram-like reactions that occur with many drugs. But the other 2 practically that are used in general for alcohol use disorder, naltrexone, metabolized by the liver. So liver compromise, alcohol use disorder, what to treat on the boards, not naltrexone. And then the third one is acamprosate, which you said is metabolized by the kidney. So kidney compromise, alcohol use disorder on the boards, avoid acamprosate. Is that pretty good?
That's perfect.
All right. I don't know if they would do, they probably could do some. I think with alcohol and the boards, probably fetal alcohol syndrome is going to be a focus of that portion of testing, and probably should be as far as the education goes, undergraduate medical education. And then the other topics are going to be like withdrawal, intoxication, probably some mechanism of drugs used to treat alcohol use disorder, probably methanol poisoning that shows up. That's worth knowing. Probably a few other things.
But if you look at the board blueprint, it does really focus on intoxication and withdrawal syndromes and how to treat them.
Yes. Ooh, zero order kinetics.
Alcohol zero, yes. That it is kind of the the poster child for that in boards. And then the other claim to fame is buprenorphine. I know that's opioid, but The other claim to fame in addiction in terms of kind of that toxicology stuff is buprenorphine is the partial agonist example in most board review materials.
Well, there you go. There's everyone's assignment for step 1, step 2, or step 3.
Those are the high yield things. And I'm pretty sure the mechanism of action of disulfiram has been on every single board exam I've taken from step 1 right through addiction specialty boards.
No comments because I don't know how useful that is that we're testing that, but whatevs.
But now they know. But now we know that we need to know it.
Yes, exactly. So now you have free question.
It's exactly. Free question.
Free point there. All right, let's move from alcohol and go to another substance. So in this question, we have a 28-year-old G3P2 at 14 weeks estimated gestational age who presents to the emergency department with intractable nausea and vomiting. She has no significant past medical history. She denies a history of trauma, is not sexually active, and has no recent hospitalizations, travel, or antibiotic usage. She admits to minimal alcohol usage and daily marijuana use for the past 3 years. On physical exam, she's uncomfortable, actively retching, has dry mucous membranes and a soft, non-tender abdomen with normal active bowel sounds. Basic metabolic profile is within normal limits. She's given some IV fluids and ondansetron with minimal improvement in her symptoms. In addition, she's given metoclopramide, but the patient still continues to have vomiting. She is found in the shower for most of her admission, saying the only thing that helps her nausea is a hot shower. What is the next best step in the management of this patient? Is it A, apply an involuntary psychiatric hold on the patient for assessment? B, provide substance abuse counseling and discharge the patient with a prescription for capsaicin topical cream? C, refer the patient to gastroenterology for endoscopy and colonoscopy? Or D, immediate consult to a general surgeon for a concern for a perforated viscus? Well, this question's...
Okay, dude, when I'm throwing up, I don't want a hot shower.
Right? That sounds terrible. Give me a cold one any day.
Absolutely. So that's kind of the key to this question, right? We are looking for what causes somebody who's vomiting to want a hot shower. And that is most commonly seen with marijuana use. So it's a good question to have in the back of your head for when you're seeing patients in terms of if, particularly around pregnancy and kind of that differential diagnosis of, are they vomiting because of the pregnancy or are they vomiting because of their marijuana use? Michigan, where I am, is a recreational marijuana state now. And so we are definitely seeing more of it in pregnancy. So we are seeing more of this as well. So it's kind of that flip of wanting to have hot instead of cold, while vomiting is a good indicator that it is a marijuana use concern. She's not really eligible for an involuntary psychiatric hold because she does not express being a risk to harm herself. And the other ones are less likely given the warm shower.
Yeah, she definitely doesn't need a general surgeon. I'm not too concerned about a perforated viscus. So I'd say answer choice B is correctly scored one, or would be the provide substance abuse counseling and discharge the patient with a prescription for capsaicin topical cream. I'll be honest, looking at this question, the addition of discharge the patient with a prescription for capsaicin topical cream would have given me pause if I were taking the exam. So it'd be like, I don't know anything about that, frankly. C is refer the patient to a gastroenterologist for endoscopy. Not going to lie, that happens a lot in this situation still. But the appropriate thing to do is to be like, hey, your marijuana use is probably causing this. So providing that substance abuse counseling to the patient is going to be the next best step in management. And just, to break this down, cannabis hyperemesis syndrome versus hyperemesis gravidarum. or any other hyperemetic state, that hot shower, super specific for cannabis hyperemesis syndrome. So on the boards, you see that, score, choose cannabis hyperemesis syndrome, move on. Are there other names for this? Like,
I don't know of any others.
Yeah, I think the boards take a long time to put newly recognized clinical entities or categorized entities, or to change classifications and taxonomies, for instance, with new updates to like a DSM. But I could see this getting on to your step 2, step 3 level exam if not now, then soon. So it's worth knowing about. But yeah, tell me about.
I think because marijuana is such a hot topic in medicine right now,
Yeah.
It's more likely to get on there faster than maybe it would have if it wasn't such a hot topic.
That's true. Yeah. Well, tell me about cannabis hyperemesis. So what's this look like? Doesn't marijuana help with nausea? Like if I have cancer and I get a recommendation from a physician to help with my pain and my nausea for marijuana, that's like a pretty common situation, I would say, to hear patients talk about. So what? Cannabis hyperemesis? Doesn't make sense.
It's that chronic use of marijuana over time that results in the hyperemesis. It's sort of like the marijuana helps with my anxiety, except when it doesn't and it causes more anxiety. That's kind of the best way to look at it.
Yeah, and that's so good too. Just you mentioned that. Like the most common, this is a little bit tangential, but still somewhat relevant. Benzos. Benzos are the only thing that help with my anxiety. Okay. Benzos are great for anxiety, but so alcohol can be, an anxiolytic. Have a rough week at work, Friday night, have a beer, you feel more relaxed. Start having a beer or 2 or 3 a day chronically. Now you have to do that or you're going to get anxious. So you can't get off it, you withdraw, you get anxious. Same thing with like benzos, and it's the chronicity of use that really induces some of these problems. And this happens a lot in medicine. Well, maybe not a lot, but medication use headaches, that concept always blew my mind. Like you take ibuprofen chronically. Now the ibuprofen you were taking for your headaches is causing your headaches. Like it seems unfair.
It is unfair. And it's really hard for patients to understand, right? Because they're like, no, I take the Motrin for my headache, doctor.
Right.
No, I use the marijuana for the nausea. And we kind of sound crazy when we tell them that that's not true anymore.
Right.
So it's a really hard conversation to have with patients. And you're right to kind of phrase that. I liked the way you phrased it, that if you do it over time, your body kind of becomes used to it and adjusts to it. And now you kind of get that rebound negative effect when you don't have it. And so that's a really difficult conversation to have with patients and a really difficult concept for patients.
Yeah. So I had a patient like this, like just a few weeks ago. And I mean, she literally was in the shower all day. Like she'd get out for like 5 minutes. She looked so miserable, and gave her Zofran, gave her ondansetron, gave her metoclopramide, tried some promethazine, the works, and nothing really helped. Nothing really helped her. And so I talked to her about I think it's the marijuana you're using. And she swore she had not used any marijuana in like 3 weeks. So I was hoping it would be like, oh, okay, cool, I'll stop using marijuana. But then she's like, well, I haven't used any in like 2 or 3 weeks. And I was like, oh, well, just wait longer. Now I like didn't know what to say, because typically.
But you're right. Just wait longer, right? The marijuana is still in her system. It's still working its way out. It can take 30 to 45 days for marijuana to work its way out of your system.
Do you know, is it typical for cannabis hyperemesis, like a timeline for improvement with cessation of?
3 weeks weeks, I would think it would be getting better, but
Yeah.
she might also still be, sometimes when people too,
Embarrassed or worried to admit.
yeah, or they say, I've really cut back, and they're still getting that like spike of intoxication, and they're kind of perpetuating it. I had a patient like that just last week where I was like, well, yeah, I'm really glad you've cut back on your marijuana use. However, this isn't dose dependent, unfortunately, so it's unlikely to get better. And then that person has two, so she's got twins in there, and so she's like, well, it's because I have twins. And I'm like, well,
yeah,
not at 32 weeks. It's not first trimester nausea that's worse because you have twins at 32 weeks. But
yeah,
those are really hard conversations to have with patients.
Yeah, because you want them to recognize. I mean, it's like, any habit. Like I was, I will admit, I was dependent on nicotine for a while, and it took me the standard 10 times to actually quit using nicotine. Why? Because of the withdrawal syndrome and the headache and the craving. It's tough. And I'm like, man, having to give up anything that you're used to doing just psychologically, like it's a part of your, you have psychological entrapments or whatever that keep it going, like reaching for the vape or whatever, and putting it, puffing on it. That's hard in itself. But then, I have a good experience with this, that feeling of I enjoy this, or I enjoyed it at one point, or, how can it be causing, a problem? It is tough for patients to get on board with. The treatment for your problem is to stop eating sugar so much, to stop using marijuana, to stop smoking. It's tough. Anything that
stop drinking so much caffeine.
Yeah, tons of things like that. Like, I'm super anxious. How much caffeine do you drink? 6 cups of coffee a day. Okay, well, might not be the full solution for anxiety, but maybe cut back to just 2, and then 1. Just see how it does. All right, just last thing to say on that. Capsaicin, I think that this is probably more theoretical, but I could be wrong. But it's the application of heat. Capsaicin's that stuff that's in hot peppers. I've used this for like musculoskeletal pain in pregnancy, but the reason that the prescription for capsaicin or recommendation for that is included is probably because the heat, just like a hot shower, or blowing a hairdryer on the abdomen. That could be another one. Could alleviate some of that nausea. And then a question on this: is there anything medication-wise that you can give to help people with marijuana cravings?
There is not anything that would show up on the boards that is FDA approved. So
thank you for that disclaimer. But do you use anything clinically or is anybody using anything, like experimenting?
People use N-acetylcysteine to help with marijuana use, but we don't do a lot of that in pregnancy. A lot of it's just that symptomatic management and offering of counseling or other support services.
Gotcha. Have you found any effects in it helping at all, or?
Not really, no.
Okay. All right, then moving on. All right, so this one, we got a 22-year-old Gravida 1 para 0. She's at 35 weeks estimated gestational age, presents to labor and delivery with a 3-hour history of chest pain, sweating, diaphoresis, nausea, and anxiety. She reports seeing a dire wolf at the hospital entrance. She works in a restaurant and describes her position as very demanding. Blood pressure is 180/98. Pulse is 120 beats per minute. Respirations are 20. And her temperature is slightly elevated at 99.9 Fahrenheit. On physical exam, she's restless, agitated, and diaphoretic. Her pupils are dilated. Urine toxicology confirms the most likely diagnosis. Which of the following is the most likely consequence of this patient's most likely diagnosis? A, abruption. B, development of preeclampsia. C, myocardial infarction. Or D, preterm premature rupture of membranes. So this one is kind of the classic story, especially you'd see on the boards. You have a pregnant woman. Basically, she comes in at term. She's got some evidence of hyperautonomic stuff and elevated blood pressure. So you're going to be thinking, oh man, pregnant lady, elevated blood pressure, she's probably got preeclampsia. But urine toxicology confirming the diagnosis is a dead ringer for some sort of substance intoxication. And with some of the findings in the vignette, she's most likely using cocaine, or I suppose another sympathomimetic like methamphetamine. And what you'd most likely see if somebody is using cocaine is abruption of the placenta, abruptio placentae. So as I like to tell patients, it's when the afterbirth tries to deliver before the baby. And the consequences of abruption are potentially catastrophic and high neonatal mortality and maternal mortality as well when not treated and clinically severe. But the point of this question, cocaine use, abruption, you should connect those two in your mind for board's purposes. But Dr. Poland, tell us a little bit about cocaine.
So the other thing to remember is cocaine is a vasoconstrictor. So that's kind of the why behind the abruption. And there could be something on board exams asking you to make that leap, right? From, it's abruption and then what causes that abruption. So that's good to know information to have. Stimulant use in pregnancy, whether it's cocaine or methamphetamine, is somewhat difficult because we don't have a pharmacological management for it, pregnant or otherwise. There's some emerging evidence, but that's not going to show up on boards. So knowing
like bupropion.
Yeah, you can use bupropion with cocaine use disorder and with stimulant use disorder, but that's really like published in the last 6 months type of new. Yeah. So we wouldn't see that on boards. I don't want to confuse people that.
Yeah, not going to be on boards, but interesting. Pay attention to the future. Future horizons.
I know, so much fun. There's so much going on in addiction, but cocaine intoxication has its own kind of syndrome. And that's what this case is about, is being able to identify that syndrome and looking at that euphoria, that agitation, anxiety, hypertension, tachycardia, elevated body temperature, and hyperactivity. And then that is that whole picture is what she's presenting with. So we want to be able to diagnose the stimulant acute intoxication, which is one of the big things on the board, is being able to diagnose different substance intoxications, and then making sure that we are recognizing the potential negative consequences of that, which really, pregnant or not, revolve around that vasoconstriction. So that's kind of the big thing. The other thing that you get can get with cocaine acute intoxication is a cocaine-induced delirium that results in visual and tactile hallucinations. We often hear the bugs crawling hallucinations is kind of the classic one for cocaine.
Oh yeah, formication.
Yes. So you may see that word, that formication or bugs crawling, as a big key into this is stimulant use on boards.
I think you see that with withdrawal from opiates, the formication.
You can see hallucinations with withdrawal from opioids, but usually that specific bugs crawling is a cocaine thing.
Well, good to know. I think we learned a lot about each of these substances and their relation to pregnancy. Hopefully some things they can take with them to the testing center, but most importantly, things that they can, keep in mind as they progress through training to treat patients with addiction in an evidence-based manner without stigma. That is the goal of this series and the work you do. So thank you, Dr. Cara Poland.
The work we do. Thank you.
Oh. again, appreciate this so much. It's always a delight.
No, thank you. This is so much fun to me. This is the kind of crap that I enjoy doing.
Awesome. No, thank you. Appreciate it.
No problem.